recorded so we can make it available to people at a later date. And we will certainly send PowerPoint slides out by email as well. So let's see here. And you can see my screen. Okay, so we will move on and go through this and then hear from So our objectives today are to describe the purpose of a baby-friendly task force, identify who should participate in that task force, and then maybe some of the goals, kind of how to divide the workload. So we have a task force for your baby-friendly journey. Obviously, it's going to take a team effort to change the culture and practice, and I certainly know from personal experience that no matter how hard one person works, you do it by yourself, and you really a good, strong task force. You need a multidisciplinary task force. And this is going to help you, create buy-in throughout your hospital, and of course, you need all those different perspectives of, going on in the facility and how you might address some of the challenges. Also, of course, to divide the workload up, and then of course is going to be your key driver. So that's going to help with communication to everyone about what's going on, and encourage continuity of care, and then hopefully, misery loves company. So can certainly help you guys stay on track and keep the momentum going, and task force can hold each other accountable for making. So who to include, and this is just kind of a one way to maybe break this down. You certainly, and I'll go through some of these individually, but you can have your core team, and that might be your team that they don't meet monthly. Maybe you initially meet quarterly. Some ad hoc members that you need to attend meetings periodically, or certainly be in communication with by email. And then, of course, break your core team up into the smaller groups that will be your more working groups. So, and a good way to do this, one suggestion that kind of sense, because a lot of these pieces together. One would be your committee, your training committee, practice committee, which is going to really look at the actual practice changes or going to be implementing. So that's step 4. And steps 3 and 10 really kind of go together as well. So that's kind of what some places call continuity of care committees. So looking at core team, of course, and you're going to have to be in charge. So identify who your baby-friendly team leader is going to be, and you may have, decide to have co-chairs. Certainly got a good, physician champion, maybe have a physician who's a co-lead for your task force. That would be great. And then, of course, the nursing staff going to be a key strong component of your core team, and you're going to need nursing leadership, and then also your staff nurses, and some colleagues and representatives from night shifts, depending on how large your facility is. If you have different areas, you need labor and delivery representatives, another baby representative. Those of you that maybe you're further along, or even baby-friendly designated, if you have other key members on the task force that include, definitely speak up or suggest that. Somebody. Okay. If you have lactation consultants or whoever your lactation are, and physician leaders, ideally you'd have someone that's presenting the OB-GYN providers, and then pediatric providers, and then many of you may have family medicine as well, so definitely try to, have someone, whether they all come, to all the meetings that are definitely in the communication mode. But certainly the more you have some physician representation will definitely help think along. Leadership, of course, maybe some type of, administrative support from hospital administration support, prenatal clinic, and then really strongly encourage trying to have some kind of community representation. And ideally, you'd have a leader that's delivered that's willing to be at the task force, whether she goes to all the meetings or not, but definitely hearing that face to face from a mother that's delivered in your facility and what was really good about her experience and what might make it better, why baby friendly would be important. Families that you're taking care of, because that's of course what this is all about. So that in a little bit. Then for numbers that you certainly want to consider, once again, depending on the size of your facility, is if you've got any type of NICU, including somebody from the NICU, because there are some questions, and we'll really hear from Kate at Comanche County, and there are a few questions that mothers will be asked during a baby-friendly assessment about if their baby went to the NICU. So you're going to be looking at documentation of breastfeeding and skin-to-skin and so forth, so you need your IT folks. Of course, quality improvement if you have people, have a quality improvement or someone that's responsible for that for the facility. Marketing, definitely, and looking at, and having them really understand what baby friendly is about, so as they're developing some new, or banners or, billboards around the community that, they plop up among baby, with a bottle in the picture or something. So we've seen that happen before. Certainly maybe somebody from anesthesia as you look at skin-to-skin contact and situations. And then where you can certainly also include their community groups to get that feedback from the community, what's happening and what are resources out there, such as community one from WIC or breastfeeding care counselor from WIC, our breastfeeding coalition. If there's home visiting staff, perhaps, you don't have to have all of these, but just depending on what's in your community, and maybe any other particular, family organizations or birthing organizations that might want to have a representative and give you a different perspective. So, right. So, what will the task force do? Obviously, your task force is going to be the key driver of this whole initiative, and they're going to be the leaders for your facility. So it's really important that everyone on the task force, especially your core team, understands why your facility is doing this. That one, is encouraging, of course, that you're holding regular meetings. Your task force can delegate responsibilities, so it doesn't mean all the work is done by just a smaller group of people. Can get more staff involved. And the task force is going to be, of course, monitoring progress and reporting back, good results and successes, and then, of course, identifying challenges. So, or planning your first meeting of your task force, and maybe you've been working some, on some of the steps already, but haven't gotten a really task force team together, then this might give you some guidance on that. So, in the first meeting, of course, and in every meeting, try to have an agenda and have someone that takes notes so that you have record of who said they did it, and to help kind of keep people on track. So, definitely want to explain, maybe baby-friendly hospital initiative is, what are the real facts about baby-friendly, what are some of the myths out there, you know, this that we're going to eliminate formula from the facility and those sorts of things. This is where you could actually, either by email or, you know, have a copy of the 10 steps, the one-pager about the 10 steps, but then, of course, the overall guidelines and criteria, which is your document. So people that want to refer to a particular section, maybe that they're going to be involved in, that they have access to that. You know, and you work towards baby-friendly, you know, isn't your hospital baby-friendly enough already? Well, you can share data from your facility. If you've got your MPINK scores from the CDC's MPINK survey, breastfeeding rates, you know, any kind of data that you have available to, and that's, of course, your starting point too, to show how hopefully you're impacting those data. And this is where you can, you know, maybe have a couple of stories from patients, patient experiences. That's definitely going to, you know, get people on board when they understand why this is important to the patients. And, of course, set some long-term goals, and, you know, this is where you can develop your committees, and I'll get into that a little bit more. And then plan, you know, some regular meeting times. How frequently will the core team meet versus your committees? So once again, at every meeting, you're going to have send a meeting reminder, let people know, give them plenty of notice so that they've forgotten that it's coming up. You know, they can try to, you know, to be there, have agenda, and then this is where, of course, you're going to, as you've assigned, you know, ask for follow-up reports. And hopefully, as you hear back from people, you'll then the core team can be the support for committees too. So if they're encountering a particular barrier, that, you know, who else do you need to bring in to address that barrier? You know, is it what the barrier? Is it with a practice change? Is it something that you need to, you know, we talked before about PDSAs, that's the little Do Study Act, or we're going to, you know, into that, but, you know, if it's, we're trying to get, you know, the doctor to do the exams in the room or something of that nature, you say, well, can we get one doctor to do this one time with one baby and see what some of the barriers are and what we need to do to those barriers. So, you know, a little one-time pilot and see, you know, what else you need to overcome that. So let's just to kind of give you an overview of what you do and how you might break your subcommittees down. So you have somebody's got to be working on the policy piece, which is step one, and you don't have to have your policy, you know, completely done, revised, approved before you do anything. But just knowing some of the elements that need to be in the policy, of course, look at if you're in the once you move into the Baby-Friendly USA development phase, then you have access to a lot of tools that are going to help you develop all of these pieces, develop your plan, evaluation plan. So there's a policy tool in there for how to develop, you know, audit if you have an existing policy, what, you know, what's in it. This is where you don't want to have some subject matter experts if you have lactation staff, nursing education, and so forth. Definitely, you know, physician involvement. Then overall infant feeding policy, this is where you also don't forget to look at other policies that may impact your infant feeding policy, or that your infant feeding policy, you know, should impact things, so that, you know, we don't have all these policies that are in silos and not, you know, really well integrated. So a good example is if you have a regulation policy protocol, you know, well, do we say anything about skin to skin in there? Or does any baby whose temperature drops immediately have to go to a warm room? Like, well, we could have skin to skin in there. So how you make that consistent across all of applicable policies. And then just to remember, let's see, it will work for me. We tried to put a lot of sample policies on the Oklahoma Resource Center website, so you can go to resources under 10 staff, and there's sample policies and forms. So we've got some policies from various hospitals, and if you go also to, actually, we go back up a bit on the resources, and then organization. Ingrid, okay, good. And then look at, like the AAP has the sample hospital breastfeeding policy. There's, that's really good information from the physician organizations to take advantage of. So take advantage definitely of they're out there. Our coalition has a sample policy as well that's been endorsed by a number of organizations. So, all right. So any questions from anybody so far? Or in the chat box that I missed or whatever, call me. All right. So the training committee, which covers 2, and start on this one. Get this one, very early, because this is going to really have huge impact, and sometimes this is the one that they gets to really implement to get all the training, all the trained and physicians trained. So you can review the training requirements. They have, good guidance in the development phase on all the pieces of information that need to be covered. To remember that your maternity staff, not all of your nursing staff in the facility, but anyone who's going to work in, the maternal newborn area, the triage, labor and delivery, mother baby, anybody that's working with the babies, but not specifically someone who mainly works in the NICU or the ER, places like that. But your maternity staff need the full package of the 15 hours of didactic hours of the skills verification, competency verification. So your physicians need 3 hours. So even though they're going to get asked all the same questions, but so they certainly have more than that. And then the rest of your hospital staff, so everybody in the facility, needs at least an overview of what the Baby Family Hospital Initiative is and why your hospital is doing this. Why is this important for the care that your facility provides? And that, can be a 1-hour thing that everybody gets initially, and then it's added in as, say, part of general staff orientation or something. And example PowerPoint that you can use for that as well. So when you have that, don't forget to make use, check out the our website and look, for any that will make some of those pieces easier. And I know, let y'all know, one of our goals that we've never been able to fulfill provide that 15-hour staff education piece, and we've gotten a small grant as a piece of that they got so that we can complete that. So we hope by next summer, in that our time frame, that an online training that's available that has the 15-hour didactic piece. Yeah. The Making Breastfeeding Easier classes that many of you have either attended or into your facility, that actually will help also account for the competency verification, or that's something that you can do that your staff at your facility as time allows. So practice committee. So this is steps 4 through 9. Because this can sometimes feel like the group that has the most to do, or definitely covers refer to the tools and information that are in the development phase, and look at those steps closely and identify some that you might already be doing fairly well, and you just need to improve your compliance or your consistency with a particular step. Maybe you've been working on step 4 with the skin to skin already, and the next piece of that is how are we doing, say, with cesarean sections or something. So go for a quick win. Look at something that maybe you're not doing that might be fairly easy to implement. So if you haven't, say, banned the bags, that's a very quick, easy. It is actually an easy thing to do. So look at taking a step like that, and that gives you an opportunity once again to educate people about why it's important. There was a really nice in A1's journal Jogging just recently about the ethics of the free formula gifts. So that's another good piece of nice summary of that whole some more background information on that. Start working now on some of the harder steps, as we've learned, and some of our people today have learned that sometimes the steps you think, you can wait to start working on the formula piece until the end when you've got a lot of other pieces in place. But some things just take a long time with the bureaucracy. So say maybe you're not ready to start paying for formula yet, but you can start the discussions with your purchasing department on how you're going to get those contracts in place. What are you going to need to do to make that change? Because it may take 6 months or a year for some of those to really piece in place. That's pretty great to work and get all these other practice changes and staff education done, and the piece that is going to take a couple of months ends up taking you 6 or 8 months, and you can't schedule your assessment until you piece. And then another one might be to kind of start looking at your documentation needs, what changes might need to be made in EMR, get the documentation elements that are to help you track your progress. It makes it easier to monitor progress. I think remember that as the staff training is implemented and your staff, more of your staff will be getting or becoming better educated, more confident in their ability to help the breastfeeding moms and babies, then you're going to gain more champions and staff that are excited about implementing some changes, or questioning, why aren't we doing this yet? And expecting that you're going to be working. So, then, last but not least, we'll call a continuity of care committee, and this is where your key community connections are going to come into play as well. So this is addressing steps 3 and 10, which step 3 is prenatal education, and then 10 is the referral piece, resources in the community as moms are leaving your facilities. So we want to include any prenatal clinic staff, whether your hospital actually manages a prenatal clinic or have, providers that have, clinics that, really send all their patients to your facility, and definitely get some of their staff involved in this subgroup, and of course, and community representatives. So those are, your WICs and so forth can really help a lot as well. What information are any of your our WIC clients? What kind of prenatal information are they getting already? And can you actually utilize some of that for your other patients? Because that's some really good breastfeeding information. And, boy, I should have put this at the top, but just remember to always be cognizant of the reading level of any patient information that you're developing, so that it's not too high reading level, and that's easy to check in. If you have the text in a Word document as you're developing new information, you can put that in when you go under Review, that Review tab in Word, and you can reading level there. So, and I'm changing because even just breastfeeding, that's 3 syllables, and that's usually considered, you try to keep really long like that out of patient information. So anyway, again, there's information in the development phase, tools on patient education requirements, particularly what needs to be covered in the during prenatal care. So, and look at all the locations where your patients may come from. You may have a clinic that your hospital manages, but then you may have patients that come from providers in the community. So you just want to make sure you're doing a concerted effort to have consistent information that those facilities are providing. As sometimes that's a tricky piece to when you don't actually manage the clinic. But understand why patients their patients need this information. You want them to understand what the environment is going to be like when they come to the hospital. Baby's room in, and we aren't going to take your baby away from you, and why that's important. That's also you need a plan for documenting the clinic that your hospital manages. But no, how are you going to identify the patient that had the prenatal education? So, and take advantage of any resources that are available, such as if you do tours of the hospital for in childbirth classes or something, there's an opportunity to get key bits of information so that the people that do your hospital tours make sure they know what to say, what not to say, and that all of the information that's on those tours is definitely baby friendly. Once you're getting information and press releases, take advantage of opportunities to get one little snippet of information into them. That would be a cool skin-to-skin picture, and get that message out there. And of course, and social media or other entities. Right? So that's really, information I wanted to share on, kind of how to have an effective task force. And then just some reminders here. Our 2016 conferences were hosting Reducing Racial and Ethnic Inequities. Again, this time it will be a full day. We have March of Dimes attending to help speaker cost, and then our 4th annual Becoming Oklahoma Summit will be on Friday, February 12th. So let's questions. I'm kind of not exactly on this. Any questions come up?
The chat box.
Okay. Anyone that has a course already that has a particular something well for your task force that they can share? Okay, out there. I think that was. Have we gotten Kate on the phone yet?
I see. And Kate, are you still there?
Yes, I'm still here.
Okay. And then I think Lauren was going to also share a bit from is Lauren still on?
Yes, I'm still here too.
All right. Okay. Well, let's see. It doesn't matter who wants to go first. know a few slides. Oops, can't use that one.
I don't have any slides.
That's fine. Let's tell you what, let's go with, we'll start with you, and then we can kind of hear from Lauren as well, since just their assessment last month. Got your slides up here. If you want to leave here, Kate, just tell me when to change the slide.
Sure.
Well, if I can stop you for a second, if we can ask everybody, I had to unmute everyone in order to address our audio issues, so you can mute yourselves or be mindful of that. Like I can hear a baby in the background.
Sorry, baby in the background.
Oh, that's okay.
In my office, we have a baby in the office. Sorry.
Okay.
Okay. We only a webinar. So that's
yeah, absolutely.
Okay. Kate Kopus. I was one of the leads for Comanche County Memorial Hospital becoming baby friendly. So we can go to the next slide real quick. We had our on-site visit back in July, right after the 4th of July weekend, and it went really well. 2 days came and gone, and we were hoping that we would hear back within 6 to 8 weeks, and it took right at 12 weeks for them to contact us back. This was just the email that Baby Friendly sent us, stating that we didn't pass the on-site assessment due to issues that they had found. So they had us do a corrective action plan and correct those steps before they would designate us as Baby Friendly. So a contact person, Christina was her name. She was really nice, very easy to email back and forth, and we talked to her on the phone a few times. And you can right there what they sent us. We had to have our correction plan within 3 weeks after they sent it to us, which we ran and sent it back probably within 3 days. And the corrective action plan had to be completed within 6 months. And Paula, manager, and I decided we just wanted to get it done and turned in. And we were able to turn that back in within 3 weeks with our information and our audits. So hit the next slide.
Okay.
Part of our corrective action plan, you can see I sent that back to Christina on September the 15th. She felt like her corrective action plan was planned. She went ahead and wanted us to follow through with our plan. So we did the audits for baby for the steps that we needed to correct. And one of them was staff training for formula preparation. So we were able to complete all of our audits, and we turned our letter back to Baby Friendly on October the 8th. And you go to the next slide, Becky. This is for our formula preparation. We have a competency booth set up at our OB Skills Fair for all the staff to come through. They had to actually prepare formula right in front of us.
Really?
Yep, they did. We had powdered formula right there, and we pretended that we boiled the water. We had hand hygiene. We had hand sanitizer and stuff like that, and each nurse went through it. Competency, probably a week later, I went and audited the staff using Baby Friendly audit tools. None of the nurses were able to correctly answer 80% of the questions, which is baby criteria is 80%. And so we did with those audits to Baby Friendly. If you go to the slide. This was an audit tool for the NIC unit. They feel like we had gotten our mothers pumping or hand expressing as quickly as what we should have within, 2 to 6 hours. And so the Baby Friendly left, I called all of our NIC unit mothers that were from July, August, and September, and I used this audit tool, and I wrote down the answers that they gave me in those audit tools, and then we were able to prove that our mothers were at 80% or above. They verbalized that pumping within 6 hours. baby-friendly wanted. And then the next slide.
So, Kate, on that note, because I know the actual day of the assessment,
Yes.
I think a couple of the members they interviewed couldn't verbalize that, so then that led them to the chart.
Right.
And then it wasn't documented. Did you have to address documentation with the staff?
We did that with part of the OB Skills Fair. We had another competency where they had like a kind of find through the policy, and I had questions and come up with the answers looking at the policy and write them down, and that was included in the policy that they need to be hand expressing and pumping within 2 to 6 hours after the baby is separated from them.
Mm-hmm. Okay.
Yes.
Okay.
And there's our designation. Yay, we found out just 5 days after we submitted our paperwork that they accepted our audits and the information that we sent them.
Wow.
So that was a quick turnaround. We didn't expect to hear back that quickly, but we did.
Yeah. I know it's frustrating to wait so long and waiting to hear that you didn't pass, that really you did pass. You just had to couple of things and send them documentation. You didn't have to have another visit, which definitely would have taken several more months.
Yeah.
So I think that's encouraging to hear. So any questions from anyone for quiet today? And Lauren, I know you're on the phone as well, and Lauren is at Intense Health Edmond, and they just had their assessment in October, so I know still waiting on results, but if you want to, share with us your perspective of how the assessment went.
Yeah, it's been about a month ago, October 20th and 21st. We actually had 3 surveyors come out. One was in orientation. She was training. Kind of ran into some issues is that the week before we were really busy, and then the week after that they were here, of course, we didn't have a very high volume. We had to do several phone calls. Majority of all of our postpartum were phone calls, as well as antepartum, except for the ones that were here for stress tests or had appointments at the clinic that's attached to the hospital. And so I did have to review a couple charts with them from the phone calls that they made. A comment about how we displayed the 10 steps throughout our hospital. They commented about how our signage was kind of temporary, and they were looking for something more permanent, like in a frame on the wall. And a lot of ours were in the clinic office in like a plastic holder or on the tables and stuff. So they were issues with that about the signage. They told us since the holidays, they said they wouldn't be surprised if it takes a little bit longer from them. So we're at the 4-week mark as of yesterday and haven't anything. We didn't have enough NICU within reach them to interview, so NICU was not, they did not interview any of our moms. They had made a couple phone calls and talked to the ones that came up for lactation appointments, but they didn't have enough volume for that as well. Overall, I feel like it went well. All of our doctors came through and went well. I'm still thinking about it, other than a couple of things with the signage, and then did have to, one of the charts that I had to review, what they were looking for, not documented. So I do know as far as it was with expression, which the nurse did not document on the patient. They said that they couldn't remember if we were taught them. And that, as far as viewing charts, I didn't pull up anything else for the look through. So I'm hoping that our patients said they wanted to hear.
That's usually a good sign, Lauren.
And then the one other chart I have to pull up that we did find the proper documentation for it.
Good. So, well, first case,
as I thought it was going to be, so that was nice.
It's not, what did you say?
It wasn't as intimidating. They were really great and very open, and I felt
very pregnant.
Yes, she was. That was her last interview before she was going to be on maternity leave. She's not going to do another survey until February.
Yeah. So, well, on the signage, worst case scenario would be that they come back and say, just, verify that you've got, a couple somewhere.
Our talk to them, so we have recently got designated pathway to excellence as well, and we're talking about displaying all these awards in a different. So she came by and talked to them about what our plans were, where we would post baby friendly and the 10 steps as well. So.
Oh, good. And that's so any surprised you during assessment?
No, anything that surprised me. Like I said, it was lessening, so I think I was prepared for, very safe, no, and it wasn't like that at all.
Yeah, that way. Yeah. So I don't know if there are.
With leadership, like our CEO and CNO, took a little bit longer than what I thought. It was good.
Anything that you would do or anything?
Just wish we had the hiring that week, really.
Yeah, you can control that, huh?
Yeah. And I had the people prepared for them to call, but I would have even gone over that because we were having a hard time with our C-sections, getting the appropriate. So I'm pulling the delivery belt and going through and trying to find some more C-section patients. So maybe just even more patients than if you have a high volume prepared for them to call. Right. Well,
I'll definitely keep our fingers crossed and expect good news before too long. So, are questions from anyone? On the and then I said our conferences coming up, and then set dates for the 2016 webinars. That I hope to do that in the next week or so and get that and definitely let us know if you have for particular topics that you would like covered in webinars. So we sit back at some that we did ago, and there's things that we need to revisit that we definitely want to make these helpful. So give us your feedback on that as well. Ingrid, anything else?
Were due to me a couple days ago, so I think most people have them in if you're in that phase, but if not, please me.
So just a little bit on the Senate. Ashton Stube, who's an OBGYN, maternal fetal medicine, has a lot on breastfeeding and lactation, and she's from University of North Carolina, and she's one of our keynote speakers, and we'll be talking, definitely about physician engagement. So we're excited about that, and then we have speakers that are going to speak on the inequity, and then also on the at the Senate is a male IBCLC who's an African American, and Muswamba Mwamba is an IBCLC, also has a Master of Public Health and works for the Dallas Health Department, and he's really established a whole program. So we're planning to have all the fathers on it this year and kind of hear from some of our dads, and then hear from about how to get our fathers engaged in breastfeeding as well. And then he'll speak on the Thursday on related, but getting how working with the African American community as well. So Anyway, so we are excited about that. And on the Thursday for the Reducing Racial and Ethnic Inequities, they have Sherry Payne from Kansas City, Missouri, and she's, I think, in nursing and an IBCLC and has a whole community program, particularly addressing women of color and breastfeeding support. So she's giving a couple of talks on Thursday, and fleshing out the agenda for that day. But I think that will be a real exciting day as well. So, all right. Well, thanks. I don't really have anything else to share. Does anyone else have any dates or announcements? Anything they want to share? Any questions about something, maybe something else that we didn't talk about today? Facing. Today, so I should put a picture in here. We've got turkeys that live in our neighborhood, so we Thanksgiving holiday and a safe holiday, and we will certainly be in touch. So keep it, and you guys are some really I know doing a lot of really good stuff, so we appreciate your efforts. Anyway, all right, we will get this in here and be in touch later. Thanks again. Bye-bye.